Your parent company here now aiming to cut bureaucracy and cover more people. Is that in line with the goals of this Department of Health and Human Services?
I think that it is. I mean, I think what I see from this group, I give them high marks for urgency and ambition, particularly when it comes to technology. We're seeing a lot of initiatives coming out of that agency trying to drive the adoption of technology. And I think with that has the opportunity to reduce a lot of the administrative bureaucracy and burdens that we face day to day, and to help us save some money.
In the last, I want to say, month or so, we heard about the formation of the West Coast Alliance, several states that are talking about providing healthcare policy as a alternative to what we're hearing out of Health and Human Services here in Washington. Is that where you're deriving your healthcare policy from?
Well, when it comes to things like vaccines, which is what they're focused on right now, nonprofit Blue Shield of California is going to follow state law. And state law right now is really clear that there's a whole series of vaccines that are covered, and that will include COVID when the governor signs a bill that just passed the legislature on that front. So I think irrespective of that coalition, California has been pretty clear, at least when it comes to vaccines, on what health plans need to cover and don't. And we will always follow the law, both federal and state law. It'll be interesting to see how this coalition evolves and the other kinds of issues that may come up along the way. It's a little hard to predict, but right now it's really focused on vaccines.
I mentioned the expiration of Obamacare subsidies. Your largest business, Blue Shield of California, as we mentioned, signed on with a group, Keep Americans Covered. And you were out with a letter, in fact, in August, warning of the health care cliff, as some are now calling it, if Affordable Care Act credits are not extended. Where's your head on this right now? The debate is underway as we speak. Do you think they will be? What would happen if they were not?
Well, I would love to have a crystal ball and be able to predict what's going to happen. I don't know what's going to happen. I think there's enough, there's a really intense dialogue, I think, going on both sides of that question. From our vantage point, like, we're a nonprofit, mission-driven organization. We would like to see everyone covered. We talk about creating a healthcare system that's worthy of our family and friends and sustainably affordable for everyone. And so anytime I think you're reducing the amount of subsidy that anyone receives to help pay for healthcare, particularly those of lower income, you're going to end up losing people from coverage if you do. And there's just no getting around that equation. The problem right now is just healthcare is just too damn expensive. I mean, it costs so much money that the average American simply cannot afford the average premium without a subsidy. Wow. And we need to address that. I mean, let's just be clear, like, we can't keep going the way that we're going. And so I think for those that are concerned about subsidies, I understand the argument, which is to say that we really are bankrupting this country with the way healthcare costs have been, where they are now and where they're growing. So we do need to address that. But I don't think the way to address that is to take people off the rolls. I think the way to address that is to get to some of the administrative efficiencies and improvements in care that will help make it more affordable over time.
Can you get to that end goal without doing the intermediate step of not extending some of that coverage? Is it possible to find the kind of best case scenario and the cheaper healthcare alternative without pulling back on some of those costs first?
Well, I think, look, healthcare's got a productivity problem. We just keep throwing more resources into it, and we're not getting a better product out of it. Like, at the macro level, there's some brilliant things that happen on the ground with any particular patient at any particular time. But when you look at the macro, the last 20 years, wages have gone up about 3% a year. Healthcare costs have averaged 6 to 8% a year. Wow. That's just not something you can continue forever. And so, and a lot of it has to do with, we just keep throwing more resources at things. And like, we still use fax machines. Like, when you go get your MRI or a test, they'll hand you a CD-ROM. I mean, there's a reason this administration has a kill the clipboard initiative, because we're still using clipboards to fill out information. How many times when you go to a hospital, as I do with my son who was in the emergency room a few months ago with appendicitis, get asked the same question 6 or 7 times. And so a lot of this is just, it's not necessarily even about the clinical care. We're massively inefficient from an administrative standpoint, and there's no reason, Creedy, to your question, that we can't pass a law that says every American ought to have access to a comprehensive real-time digital health record on their phone or their favorite tablet. They do it in every other aspect of their life. That can lead to huge efficiencies administratively, not to mention a way better experience for the average American.
Interesting. As a parent who's brought a child to the ER with appendicitis, I see you, and I hope everybody's okay. You've said a couple of things, including healthcare bankrupting America as we know it at some point here in the future. And it brings me to the fireside chat that we saw you deliver at the America's Health Insurance Plans lobbying group here. You talked about a cliff, separate from the Obamacare cliff that people have established at the end of the year. You said, we don't know how far away it is. We just don't know when we're going to fall over the edge. Let me put it another way. Your business in healthcare is not sustainable if the industry is not sustainable. If that's your perspective, who's to blame, and how do you fix that? Is it possible to avert the cliff?
It is possible to avert the cliff. I think everybody is a part of the problem and everybody's a part of the solution.
Wow.
Health plans, hospitals, physicians, pharmaceutical companies, everyone in the industry right now are not doing all the things that they should be doing. And yet they're also doing some things that are really contributing positively. At the end of the day, this system is fundamentally flawed. We pay by the volume, and we pay for volume. If you're going to get paid as a physician, you have to see people and have office visits, or you need to do surgeries. If you're a hospital, you need to keep people in the hospital or have them use the different services. If you're a pharmaceutical company, you need to get, like, everything's about volume, and so we churn out as more volume, but not necessarily better outcomes. So that system needs to shift. There's three things that need to happen. We need to pay people differently so that we're paying for outcomes, better healthcare, not more healthcare. We need to make it digital and simple, like I mentioned before, and take a lot of administrative cost out of the system. And then finally, we need to truly personalize it. And I do think that there's both technology and other processes that can help us do that today.
You mentioned some of the pharmacies as perhaps one component of the issue. It's been brought to our attention that you have recently cut CVS Caremark from your business and are purchasing directly from drug manufacturers. Can you just explain the logic of that move and why more of your peers in the space aren't doing the same?
Well, this space is the classic example of more is better as opposed to better is better, because you have a situation where there's multiple players in the distribution system between the pharmacy manufacturer and the patient, and they all get paid more money when we sell or administer a higher volume of more expensive drugs. So guess what we do? We sell a higher volume of more expensive drugs. Great example, Humira is an injectable drug that's used for things like rheumatoid arthritis. It is the single drug in 2024 that Blue Shield of California spent the most money on. It lost its market exclusivity in early 2023, which meant that companies could offer what are called biosimilars that could effectively do the same thing because there was no longer a patent exclusivity on that drug, and potentially introduce competition, which they did. We ended up, as a result of this model that you mentioned, contracting directly to get the drug. So Humira in 2024, the list price was around $7,000 per month. The net price was around $2,100 a month, which means when you take all the rebates and fees out that were going through all these intermediaries, the actual reimbursement to the manufacturer was around $2,100. We negotiated a deal for $545.
Wow.
And so that's the kind of thing that's going on. But at the same time, in 2024, despite the fact that these deals were out there, Humira had more than 90% market share for that drug. And that's because all the players were getting rewarded for selling and administering a more expensive drug when there were less expensive options available.
What do you do with GLP-1s? $1,000 a month for Zepbound.
Right.
If this drug class is truly about to go mainstream, does this break the back in a similar way?
Well, it's just too expensive right now. I mean, it's when you think about it, and I was talking to a group of drug manufacturers recently about this. Like, the average total insurance premium per person that Blue Shield collected for people that get their insurance through their employer in 2024 was around $330 a month.
Okay.
This drug is being priced at more than that per month for one patient. So there's simply no way economically that you can cover the drug at that price for all the people that would like to get access to it. and keep it economically sustainable. But to me, this is an opportunity. This is an example of an opportunity to say, well, let's think about a different payment model. If we were to think about a way to pay the manufacturer to actually help people lose weight and get healthier and get their costs down, as opposed to every time you sell a pill or an injectable, you get more money, then there's a way for them to get rewarded financially for helping, but only when they help people actually get healthier, when they help them lose weight. Because one of the challenges we've seen with these drugs is not just their total cost, but there's a lot of people that start on the drug and then come off, and then they don't get the benefits of it. So you get the cost up front, you really don't get the benefits of it in the system, and ultimately what you're looking for is these drugs they're incredible innovations. They have a tremendous potential positive impact on healthcare for people. We want people in the right circumstances to access them, but we want them to get the benefit of it.